for signing in to this month's CTTG research methodology rounds. And today we have two speakers who are both highly recognized in their fields, and we're going to be speaking on the topic of health data sharing in Canada, a case of study of achievement. So to begin, we're going to have Dr. Chaim, who is a professor in the Department of Medicine and the Institute of Health Policy, Management and Evaluation at the University of Toronto. Dr. Bell is a hospital-based general internist, scientist, and chief of medicine at Sinai Health System, and is also an adjunct scientist at the Institute for Clinical Evaluative Sciences in Ontario. And he will be joined by Amol Verma, who is a physician scientist, assistant professor in general internal medicine at St. Michael's Hospital and the University of Toronto, and the 2023 Temerty Professor of AI Research and Education in Medicine at the University of Toronto, and is a health sciences researcher studying to improve hospital care using electronic clinical data. And Amol co-founded and co-leads Gemini, one of Canada's largest hospital clinical data research networks, which is collecting data from over 30 hospitals in Ontario. And I won't read out all the various publication and awards that these two speakers have, because that would probably take up the remainder of our time today, but they are very highly regarded in their field, and we're quite happy to have them join us and talk to us about what they have been working on. And with that, Dr. Bell, I will hand it over to you.
Thanks. And the meeting is being recorded. I just clicked off on the OK, I think. Yeah. Thanks, Jacob. What a treat for me to present to you, and also a treat for me to listen to what Amol is going to say afterwards, because I think it'd also be a treat for everybody else. They've just a spoiler alert that Amol and Fahad Razak, his partner in crime, have really put together an amazing group called Gemini, and I think it'll also be a great opportunity, if you haven't seen it before, but for this type of group to really see what they put together, and an amazing platform to build upon. I've spoken with some people, some of your colleagues who aren't on right now, about hopefully building upon this for some of the transfusion-related data. So without further ado, I'm now going to share, hoping that I can get it here. 1 second. Everybody see that? I think I'm just going to...
We're seeing the presenter view. If you can do this swap.
Yeah, oh, there we go.
There we go. Perfect. Got it.
Okay, excellent. So what we're going to talk about, Amol was also on the panel with me, so it's a very nice complimentary presentation. However, this is the first time we've done this type of tag team. So if there's any feedback or constructive comments, please let either Amol or myself know. As I said, this is the first time, but we thought this would be an interesting thing. We're going to hopefully leave a lot of time for questions and your comments. But if you could hold it to the end, or in between the two, for comments on my part of the presentation or questions, then we'll be able to get through it and then discuss things afterwards. And that's the intent. So the outline for today, I want to present a context of the national report, itemize the process we went through. We're going to I'll present the summarized report and then describe some of the panel reflections. This is a panel that you'll see, and some of the players you'll recognize. I'm going to talk a little bit about the report follow-up, and then the fun part, I think, is where Amol gets to present the case study and really to see what the opportunities are in this. The only thing I'm going to say is, normally with a clinical talk, I have a clinical question at this time. I really couldn't think of one that was appropriate, but Amol will probably bring something in, I'm sure, in his focus. So here, the charge that we had, and this is a group, the Public Health Agency of Canada asked a group that called the Council of Canadian Academies to convene a panel of experts to answer the following question. I was asked by the Council of Canadian Academies to chair this, even though I wasn't technically a member of the Council of Canadian Academies, but this is what the Council of Canadian Academies does, and they bring in all sorts of expert panels. An example of a previous expert panel is one on antibiotic resistance in Canada that was recently chaired by Andrew Morris. Another one was that's gone on to a lot of focus has been on medical assistance in death, and they were some of the early people in that area. So what we wanted to talk about was what are the opportunities for maximizing the benefits of health data sharing, and the concept. That's the main question, and then some of the other ones looking at socioeconomic impact of the current approach and the risks associated with both maintaining and enhancing data sharing. And really what happened, so before I talk about it, I'm going to really talk about the panel we put together, which was an amazing group of people. You can see I'm on one side, Amol is kitty corner to me in a sense at the bottom right. But what we had here are some of the people, at least locally in Toronto. You might recognize Moira Capro, who's been involved in health services research, particularly in the stroke area with the Canadian Stroke Network for a lot of time. And Beata Sander, who's been involved with and most recently was involved with modeling for the Ontario Science Table. Robin Tamblin was the head of the CIHR Institute for Health Services Policy Research, and a lot of these people had unbelievable expertise in their subject matter areas, either in public health, health law, and health policy. So really an amazing group of people from across the country. The context that we were looking at was a context at the time was a COVID pandemic exposed the shortcomings and limitations of our current approach to health data sharing. We recognized that we really couldn't give a national idea of what was happening in the country regarding either the infection or even identifying hotspots, as we did in some parts of Ontario, for example. We also couldn't translate that into vaccination status. But it wasn't just COVID, but that really brought it to the forefront. And it recognized that we really lagged other jurisdictions. When you saw it on the global scale and from a comparison, we showed how far Canada is behind any of these innovations. And the idea was that the government of Canada at some point had signaled its intent to develop a pan-Canadian health data strategy. Now, just so that you know, we don't use the word federal anymore in Canada. It's like an F word, but you can use pan-Canadian, it seems. And that's just the idea about recognizing the autonomy of the provinces and the territories with respect to healthcare. And then smaller scale initiatives in Canada really have already demonstrated the value and benefits of health data sharing networks. So this is the formerly Institute for Clinical Evaluative Sciences, ICES. There's the Manitoba Centre for Health Policy and the Health Data Research Network, HDRN, are real examples of particularly in the research space on the benefits of health data sharing. But we wanted to go beyond that as well. So the report had about 6 points. I'm just going to focus in on a few of them here. The benefits of health data sharing, we sort of identified many of them, which looked at improved quality of care and health outcomes, reduced burdens on health professionals. So if you look at it from a patient perspective, you can look at a patient, you can look at a provider, you can look at it from a meso aspect or a macro aspect, public health. But you also have to think about it in terms of government with more cost-effective healthcare, the idea about innovation in the health sector and how that translates into innovation in the economy, and then the idea about patient access as well. The benefits of anything when you're looking at health research in this specific area was obviously large sample sizes. I'm already preaching to the choir here, I think, but you're also attracting talent. You can reduce the costs when you have those economies of scale. And then the idea about multidisciplinary teams. The other concept, and this is a concept that you would know, would be about the increased efficiency in clinical trials. What I like to term this sort of the learning system is just a giant PDSA cycle. And it's the concept here that in order to get the accurate data into your quality improvement process, it's much easier if you're using a digital data capture and you're moving towards more real time. I'm sure Amol will talk a little bit about this, but in general, many of you who have ever undergone quality improvement processes recognize that a lot of the effort is in data capture and data acquisition, which sometimes even it's done in pen and paper. Clipboards are the classic. But really, you should be instead of taking your time dedicated to data capture, it should be really in data analysis and other elements of that, the plan, do, study, act cycle. So here, the learning healthcare system is one where all parts of the system lead to an iterative cycle of improvement. So again, I think I'm speaking to the choir here, but the cost of implementing a health data sharing system are likely to be offset by its economic benefits. And in the report, we identified this in the medium. It even comes in the medium term. You don't have to look at a long-term return on investment to see that balanced tip. But it can also get better value from the investments that we've already made in digitizing. The analogy I often make is that even if you spend an enormous fund of money on implementing a new electronic health records, it's not just a health record. That's not where you achieve the benefits. You achieve the benefits when you put the new applications up and integrate them into the health data system. So you need that foundation, but you're not really helping anyone until you use some of the tools that require that electronic health record to be implemented. So some of the economic costs and benefits, and of course, with the inflation rate the way it is, these are now gross underestimates, but they're somewhere around the reducing health system inefficiencies. We're looking at upwards of 2.5, probably now closer to $3 billion, billion with a B. The other interesting things that it's very difficult to recognize and very difficult to account for the same way as clinician time savings, but those are enormous, and particularly in the realm of the recent realm where we're looking at challenges with physician wellness and health human resources. Those are not to be underestimated. And then, of course, there's patient time savings. And this is where you get at that interplay between direct costs and indirect costs. But all of you know that anytime an older patient, for example, is brought to the clinic by their family member or a younger person, there's often a half day, a full day of loss of work or loss of productivity on the side of the person. Just because the patient may already be retired doesn't mean that the people taking them there are, and how they're included. So these are just direct patient time savings, and not necessarily the indirects that you might see. So benefits for patients, of course, are looking at primary care visits and emergency department visits thought to be unnecessary, direct and indirect cost savings, and time savings, right? But this is where that a lot of these risks have loomed quite large and have, I won't say paralyzed, but have it's slowed down, extremely slowed down the progress in any of these. The biggest things, it's not as much the stigma and bias. Everybody always talks about the insurance companies having access to data and how people's insurance fees might be affected. The other idea about privacy and cybersecurity. The concept of inequities and the digital divide have often, those discussions have said that we shouldn't move forward because not everybody can move forward at all. And of course, we have to always be careful and cognizant of burdens on health professionals. The unintended secondary uses is always the scary thing that people are thinking about. But what we felt is that now we're no longer at the vanguard. We're so far behind that in order to play catch up, the risks of not enhancing health data sharing at this point are far greater. And a lot of the people before us have sorted out a lot of these challenges that we've identified that have prevented us from moving forward. So some of the things that we saw that are common in other international systems in this context are that there are single points of access for patients, practitioners, and researchers. The data privacy and security features are there to promote promote public trust. It could be a federated or a decentralized infrastructure that required, but it had the idea about it being institutionally agnostic to governance arrangements. It doesn't necessarily need to be tied to institutions or existing institutions. And these are some of the common aspects. So this is some of the report that we brought together and the advice we shared on implementing these things. And the idea about implementing these need to be early and sustained public engagement to build trust. And this can't be underscored enough. The idea that it doesn't have to be a big bang, that we can do different parts, we can bring different parts online at different times so that we can have incremental approaches to building that trust and to demonstrating success. And then there's a concept of financial incentives or regulatory mandates to encourage participation. This is sometimes the idea of the carrot and stick phenomenon, but they need to be thought through pretty well and understand what the barriers to this are. Most barriers, the data sharing are fundamentally political and cultural and not technical. It's the idea that people always focus on the problems with cybersecurity and some bad insurance company getting a hold of it. But really, what we found was that there doesn't need to be, at least to make significant progress. We don't need new legal or regulatory regimes. They might help in some areas, but we don't need that to demonstrate real progress. What we do need is some collaboration. And this is where we really identified something called a culture of caution in Canada. And we felt that that's been one of the largest impediments to moving forward, is that we're beyond cautious, and any of the advantage we had in moving forward over the previous decade is completely lost, where others have come forward. And the concept that we're bringing forward here is that it changes from a culture of custodian to a culture of stewardship. The idea that you're the keeper of the data and that you have to protect the data, to one where, of course, you have to protect the data and have the safeguards, but the idea is that this data should be shared, and how we help that happen. So this is where we talk about the culture of caution and data governance, and moving from the custodianship model to a stewardship model. And we don't need regulatory framework. So this was a lot of the conclusions, which I think were, for many of the people involved, went against the conventional wisdom. The conventional wisdom at the time often were that we needed a lot of new legislation, and that's difficult to put in, and that's slowing us down and preventing us from making any real progress. What we're showing here is that it's more of a mindset that we need to overcome, and that what we already have in place can help us, and that the issues are more political than technical. So what we are proposing is a pan-Canadian health data strategy to help address the fundamental issues of federalism and jurisdiction. We wanted to look at Indigenous jurisdictional authorities and Indigenous data sovereignty under this, and under the United Nations agreement. And it requires a governance model that does not depend upon the federal government for leadership, or at least solely on it. And I think that's one of the things that we focus on. I'll talk about this in a couple of minutes. The pan-Canadian, what we proposed is a pan-Canadian Health Data Science Agency. We didn't go with an acronym, and that certainly is a mouthful. But it's the idea that there's an arm's length or institutional agnostic entity that works to coordinate data, and that their job is to make sure that they have data. They're not necessarily the holders of the data, but they're people that help to break down those barriers. Examples of such entity are in many international jurisdictions. And one of them we brought up, interestingly, I'm interested for your thoughts about this, is with Canada's blood system. in that realm. The goal, of course, of this proposed agency is really for collaboration and coordination across various actors, and the idea about serving them rather than supervising them, rather than holding data. And you need a common framework of standards and policies for health information exchange. So the summary that we had was that building on existing small-scale health data sharing networks in Ontario, we have the capability, we have the technology, and if many of you probably are old enough that's actually the start to the old thing, the $6 million man. We have the technology, but the idea is that the flexibility we also have the legislative frameworks to make significant strides forward. We don't have to talk about legal reform in order to do this, and it's an idea of a change in mindset from a culture of caution to one in which there's custodianship moves to stewardship. And the idea is to establish an independent organization that was mandated to coordinate data sharing, so that institution. Now, what people said, and I'll talk about this in a second, what people said is, why don't, CIHI is that entity. And I said, that could be the case, but why hasn't CIHI done it already? And part of, I think, and this is this is part of the things I'll talk about when we talk to CIHI about this. And it's the idea is it doesn't matter who it is, but CIHI's focus is also a custodian. They're a data warehouse. They hold the data. So that the concept here is not necessarily one where they might be in conflict if they're both the steward and the custodian. And so that's why it could be CIHI, but it would have to be an agency that's related to it that has a different mandate. So the reason we did this report, the reason we timed the report the way it was, we were supposed to present at a First Ministers meeting in December of 2023. That didn't happen, unfortunately, and we're trying to get back on the docket. It's not an easy thing to get on the agenda for First Ministers meetings, obviously. That was extremely disappointing. I was interviewed for the Globe and Mail prior to the completion of the report, and it was integrated into other things and got some press coverage. Sorry, that shouldn't have been there, but the benefits and risks of enhanced data sharing has been presented to many places, and it was presented to the Public Health Agency of Canada, that was the sponsor of this. We presented to the CIHI, and I told you a little bit about what some of their issues with it were, although I don't think it's insurmountable, and we didn't give recommendations. We just identified some of the challenges that could be if they take on that role. Health Canada and CIHR, and to recognize that these were presented all to the senior leadership of those entities. So that's sort of where we are. Just to outline, I just wanted to say what I sort of looked at some of the context of the national report, itemized the process of how we went through this in a pretty elaborate way. I didn't give a focus on how the reports were done, but it was quite rigorous. Presented the summarized report, presented some of the panel reflections and the report follow-up. Now I'm getting a treat, and you all have a treat of Amol taking over to really talk about a practical application about this. So thanks, Amol, and then I apologize for being a bit late, but hopefully we'll be able to make up some time with Amol, and then we'll have a discussion.
Yeah, absolutely. Thanks so much, Chaim. And can everyone see my slides and hear me okay? Yeah. Okay. So I'm delighted to share with you a little bit about the work that we've done with Gemini, which is a hospital data sharing network in Ontario that I co-lead with Dr. Fahad Razak, as Chaim mentioned. So Gemini actually really started with a very focused clinical question at its outset. We started with the question of what is the quality of care for general internal medicine patients, and we started collecting data from hospital information systems at 7 hospitals in Toronto. And that was in about, the idea started in about 2014, and we received our first data set in around 2016, 2017. We have since grown in scope, so that now Gemini collects electronic clinical data from about 30 hospitals all across Ontario, representing about 60% of Ontario's patients. And we collect data not just for general internal medicine, but any medical department. So from cardiology to oncology to hematology, and any ICU admission, whether that patient is there for a surgical or trauma or other reason, as well as any medical reason. So the important areas of hospitals that we currently don't collect data on are surgical, obstetric, inpatient mental health. But actually, excitingly, Gemini has also just recently been funded to expand to include pediatric care in the province. We collect the data under Research Ethics Board protocols at each hospital that governs the collection of the data and in broad strokes governs the use of the data as well. And there are bilateral data sharing agreements between each participating hospital and our central hospital, Unity Health Toronto. What's really nice is that overarching structure makes it quite streamlined for researchers to use the data, and I'll talk a little bit more about what that access looks like. The data are stored in a computing cloud called HPC for Health, which is hosted at the Hospital for Sick Children in Toronto, and allows the data to be used in a very flexible computing environment that is useful for computationally intensive tasks like machine learning. And we've tried to make that environment as user-friendly as possible while still being highly secure. And we currently hold data for about 2.4 million hospital visits. The data are remotely accessible in that environment. They're accessible to hundreds of scientists and students have accessed that data, and also many hundreds of clinicians have accessed the data to get performance feedback, which I'll talk to you a little bit more about. We currently have more than 100 active research projects, and more than $80 million in grant funding has been raised by researchers who are using Gemini. And the most important thing about that statistic is actually that more than half of that funding has gone to institutions that are not Unity Health Toronto. So we really see this as a system and network-wide resource for people to use and support their own research and quality activities, so that it's not primarily, our own research programs. In terms of the data that are collected, so we've talked, Chaim spoke about CaiHi, and they collect really critical data about, our administrative data. So that includes a lot of details about, patient demographics and conditions that are already reported to these administrative databases and already shared. But what we do is we layer onto that detailed clinical data from the hospital's electronic medical record, so that you can paint a much more granular picture about a patient's hospitalization. And probably of most interest to this group is our transfusion data. So this diagram, which I don't expect you to be able to read, is all the data tables that are contained in Gemini. It's called the entity relationship diagram. If we specifically zoom into transfusion data, so we get this data from the blood bank information systems at each hospital, and we collect some quantity of data, some data from these sites. And we've since learned from our collaborations that I'll be able to share more with you about, that there are some really critical elements that we don't collect that we may be able to collect, such as product code information from CBS, that if we could collect would allow linkage to a lot of other really important and interesting opportunities. But we do collect currently sort of the name of the blood product that are issued from the blood bank, the number of units issued, when they're issued, the quantity, and then we have done some standardization around that to a common data model as well called OMOP. We've spent a lot of energy focusing on data quality. So the data that are extracted from a hospital information system should not be taken at face value. And so what we did was we sent people in to every one of our initial hospitals. And now every time we receive a batch of data from participating hospitals, we actually do some manual validation. So our site leads at each site pull up a certain number of charts and compare the data to make sure that we're collecting the data that is important. And once we do that, and we actually find problems every time, we find errors, we fix those errors, and we've been able to achieve a high level of accuracy in the data that we collect compared to manual review of the medical record, including for transfusion. This is specifically validation around red cell transfusion data. Receiving data from the hospitals is complex. I'm not going to walk you through the specifics of this figure, but essentially what happens is this first, we call this our swim lanes diagram. So the first swim lane at the top is the participating organization, so the hospital, right? They extract data from their systems, and then they send it to us at Unity Health Toronto, the second lane. And we spend a lot of time first de-identifying the data, so dealing with privacy. That's what happens in this zone, zone 1. Zone 2, we do a lot of work on data quality, assessing the data quality and standardizing the data across sites, because each site has their own data that is very unstandardized. And once all of that data has been transformed and standardized, it then can be used for research. And it can be used for research in a zone that's just locally held at our hospital, or pushed to HPC for Health, which is that remotely accessible environment for people to use. And then finally, at the bottom there, the data are linked at ICES. So ICES, Chaim mentioned, as a repository of great linked administrative data in Ontario, allows us to look at things that happen before and after the hospital visit. And so researchers can really access data in different ways. They can access linked data at ICES. They can access data directly themselves at HPC for Health, and they can contract a Gemini research analyst to do analysis at Gemini. This is critically important, this point on the side. So probably the biggest limitation of data with Gemini right now is that hospitals transfer us data every 3 to 12 months, with the vast majority of hospitals really transferring that data every 12 months. So there are big lags in the data, which is really important, for example, for trials, like what kind of trial you can do with this data. We're hoping to really narrow that to closer to at least every 3 months for sites, and ideally moving towards real time, but that's really our work over the next, year, 2 years, or maybe longer, to try to figure out how we can close that gap. Just at a high level, Chaim mentioned that it's not specific privacy legislation or regulations that are the barrier to sharing data. It's really a cultural thing. There is a lot that can be done within the existing legislation. And one of the things that we've done is take an approach that many organizations are increasingly using, which is a zoned approach to sharing data. So we collect personal health information for individual patients, like their health insurance number and things that are really private. That is stored in a very carefully guarded zone of data that is only accessible by a very small number of staff. We then, once we've de-identified that, stripped out those direct identifiers, we have raw data. That raw data still contains information that maybe is a little bit more crude and could have a bit higher risk to patient privacy. So that's held in zone 2, and it's restricted only to our data team. And then zone 3, we've now formatted and standardized the data really nicely and put it in databases for use. This is what's made more widely available to users in remotely accessible environments. And so, having this zoned approach allows us to share data. The colloquial catchphrase people use is as openly as possible, but as closed as necessary, right? And so, we're able to kind of walk that line between making the data usable but still protecting it. In terms of how researchers can access that data, so we have a streamlined, it's like a 2 or 3 page project proposal form that just asks researchers to highlight at a high level what's the research study they want to do, and describe it in a fairly high level. That's then reviewed by our projects and publications committee, which is composed of Gemini investigators from across many of our sites. So it's a multi-institutional group. They review that form within 10 business days and get back to you. Because of our process of the intake, where in order to prepare that form, you actually work with one of our Gemini investigators who coach you through that process. We actually have I think it's like a 98% approval rate on these projects forms, which is great. And then once a project is approved, we initiate a parallel onboarding process where if you want to use our system, you need to onboard to our hospital. And so that there's some paperwork involved with that. And simultaneously, our research ethics board at Unity reviews every one of those streamlined proposals, which is logged as an amendment to our parent REB. And so what that means is every single project has good REB oversight, but that all happens within about 4 weeks from when you submit your form to when you can access the data. Somewhere between 4 and 6 weeks, you have access to your data, which we feel is obviously it's, not totally seamless, but at the same time, it's quite streamlined. We have a team of roughly 30 to 35 amazing people who help us make all of this work. I'll just give you a couple of quick examples and then close so we can have more time for discussion. So first is just how do we use these data for audit and feedback to clinicians? So I mentioned that we started out trying to understand the quality of care delivered on general medical units. So these units represent about 40% of emergency department admissions to hospital. It's the largest group of inpatients. Most patients end up on a general medical ward when they're admitted to hospital. Before our work around this activity, there wasn't really a systematic approach to measuring and improving the quality of general medicine care. We had a lot of work around cardiac care, around sort of specific areas, but general medicine is such a grab bag that people didn't know how to wrap their heads around it. And so we did some research and we started looking at physician practice variation. So this was one of our first studies that we published in the BMJ Quality and Safety. Across the initial 7 hospitals, so hospitals A through G, we looked at physician variations in hospital length of stay, mortality, use of blood work, use of imaging, readmission, etc. And here's what we found. So here's just an example with hospital length of stay. You see striking variation. So take hospital A, the average length of stay for general medicine patients was 4.9 days, but you can see a huge spread across physicians. So some physicians had lengths of stay as long as 5.8 days, and others were down at 4.8 days, 3.8 days. And so, aggregated across the several thousand patients cared for on a general medicine unit each year, these effects really have a huge impact on how we use our inpatient scarce resources. An important thing about general medicine care, which is very useful for studying variations in practice, including variations in transfusion practice, which we'll talk about in a minute or two, is that within a hospital, patients are essentially randomly assigned to general medicine physicians, just depending on when you happen to be on call. So usually there are 5 doctors on call, and patients just kind of get sorted out to the 5 teams in this sort of quasi-random process. What that means is if you statistically look at the differences between the patients cared for by all these doctors within a hospital, they're very well balanced. And so patient differences do not explain practice differences that are observed, which is really useful for understanding causality and for giving us an opportunity to actually understand practice variation. So we started working with Ontario Health, the agency that's responsible for healthcare quality and administration in our province. What we did was we took the Gemini data, we turned it into quality reports that Ontario Health delivers to physicians and hospitals within the network, and then bring those groups together in a community of practice to implement focused activities to improve the quality of care. And this is called the General Medicine Quality Improvement Network. And so we deliver reports that look like this. And if we have time, I can pull up an interactive report and show you what the report looks like. But this is a screen grab. So one of our indicators is appropriate red blood cell transfusions. So this is, we looked at a definition that aligned with some Choosing Wisely recommendations and others. And what we said was, a red cell transfusion where the pre-transfusion hemoglobin was less than 80. So we were a little bit liberal with that threshold, but we said, okay, if your transfusion was pre-transfusion hemoglobin was less than 80, we'll call that potentially appropriate or likely appropriate. And so then each physician gets their rates of appropriate transfusions, and they can see how they compare to their colleagues within their hospital. They get it broken down by disease condition, so they can see maybe where the gaps are. And this is a bit of a mock-up for data, so don't interpret this as real data. Otherwise, you might wonder why so many patients are getting transfused with UTIs. But it gives them some insights as to the conditions, and then they can also see how the practice has changed over time. We also produce hospital level reports. So this is actually real data. So this is real data for my hospital, the appropriate red cell transfusions. And what you can see is at my hospital, 94% of patients receive an appropriate red cell transfusion. It puts us in the middle of the distribution here across the province. And in general, actually, most hospitals have very good appropriateness of red cell transfusions according to that threshold. But there are some hospitals that actually have a real room for improvement. The hospitals can see how their trends have changed over time, et cetera. So these are the quality reports we give. And so in that context, we're really excited to have started working with a group of transfusion medicine specialists on a project called Gadget. And these are slides prepared by Dr. Raza Shahryar, who's a transfusion medicine fellow with CBS and at U of T. And it's a group that includes many people from across the country. I see some on this slide, like Nali and others who've been working really closely on this work. So I'll just tell you a little bit about it. You may have heard something about it at the recent meeting in Montreal. So I apologize if there's some repetition here. So within Gemini, we currently hold data for about 31 institutions. 25 have good red cell data. There was 5 where we found either one was like a smaller hospital that doesn't do a lot of red cell transfusions, and there was others where either they didn't have sufficient data over like the relevant time periods, or there were some data quality issues that were identified that we need to work through. And this is part of the process. I think Chaim mentioned, needing to be iterative in the way we think about health data sharing. Like, it's definitely not perfect at the outset, and this is truthfully one of the best things about the work of having transfusion medicine specialists dive into the data deeply is they have been able to find data quality issues that we didn't know before. I mean, we're a group of like internists who put this thing together, right? And so you're able to bring an expertise to the data that is really strengthening the value and the use of the data in a way that is wonderful to see. And we're really grateful for that collaboration. So what have they found so far? 1 in 9 encounters involved a red cell transfusion, and we have data for more than 300,000 red cell transfusions. Just some of the findings here. So we mentioned pre-transfusion hemoglobin. So this is the sort of distribution of pre-transfusion hemoglobin among those who receive transfusions. And unsurprisingly, 69 is that big cutoff. Based on what we know about transfusion, recommended transfusion, like thresholds, I guess, in the literature now. What's interesting is this metric that the team has developed to look at transfusion probability. So it's basically if you have a hemoglobin of 70 followed by a transfusion divided by all hemoglobin results that are 70, and then you can do that at every hemoglobin threshold. And so what you see here on this plot, which is really nice, is that the probability of transfusion dramatically increases at around 70, right? Which obviously fits with our clinical intuition. But you can, and fits with generally the distribution of transfusions. But you can see that there's actually this little hump over here, right, of patients who are getting transfused at a different transfusion probability. And if we deconstruct that by conditions, we start to see that, yeah, probably a big chunk of that hump over here is for certain conditions like MI or active GI bleeding, where you might have a more liberal transfusion threshold. So this is a really nice validation of, I think, clinical practice and also this metric. What's really exciting then is if you apply transfusion probability by hospital, we see some hospitals that have a different distribution. So most hospitals have that same pattern of this transfusion threshold at around 70. But there's some who have a different pattern. And now I think the first thing you'd want to ask is, are they caring for more MI patients? Are they caring for more GI bleeding patients? But if not, maybe these are outlier hospitals and represents opportunity for improvement. The second way that we could slice this data is looking at the patterns of transfusion. So there's the Choosing Wisely Canada's recommendation. So why use give 2 when 1 will do? So we're trying to get away from the habit of automatic prescription or ordering of 2 units of blood. If you just look at the data crudely, you can see that actually it's very uncommon, relatively uncommon, to have 2 units be ordered at once. But what's really interesting is if you decompose this by hospital, so these all represent a different hospital, and you look at the ratio of the number of units, the number of times basically they're prescribing 2 units versus 1 unit, you can see there's a 7-fold difference between the hospital that's the most sparing in the use of 2 unit transfusions and the hospital that uses the most. And again, highlighting a really nice opportunity for feedback and improvement. So I'm just going to close with what I hope is a really interesting and potentially inspiring example. So we looked not at the transfusion literature, but we looked at antimicrobial prescribing in a partnership with some researchers at UHN and Sinai. So Mark McIntyre is a pharmacist who led this work along with Andrew Morris and others. And published a paper. We just looked at, so they just started by looking at 4 hospitals. They looked at antimicrobial prescribing. So the first metric here is days of therapy. So how much antimicrobial drugs are prescribed. And then this is the breadth, the spectrum of the use. So are you prescribing more potent or less potent antibiotics? And so what you can see is across these 4 hospitals, there's a huge spread in each dot represents a physician. So there's like a 40% difference at some hospitals or even more in the use of antibiotics across all patients. And there's a wide range of difference in the breadth of antimicrobials that are used. And what's really interesting is those differences are not associated with better clinical outcomes. So the people that are prescribing more antibiotics, their patients do not have less in-hospital death. They don't have less ICU admission, less 30-day readmission, or shorter hospital length of stay. So it's the excessive use of antimicrobials is not buying better patient outcomes. And so this, again, highlights a really important opportunity for improvement. And what's really exciting is we were funded by CIHR to conduct a province-wide pragmatic randomized control trial of audit and feedback to safely reduce antimicrobial prescribing. And I think the Gadget team has a vision of basically doing something similar, creating an opportunity to provide feedback to clinicians and hopefully improving the appropriateness of transfusions, not just across red cells, but other kinds of products. And I think what's exciting about this is it highlights a certain type of trial that you can still run even with the data lag of 3 to 12 months. And so I'll just conclude there and say thanks so much for inviting us to share the work with you. We're really excited about making Gemini a resource for many people to use and would love it if you feel that it's relevant to your network, but also if anything we've done along the way, whether it's our data governance policies, our approach to RAB, et cetera, if any of that can facilitate your work, we'd be more than happy to share. I think to Chaim's point about the learning health system, it would be really a shame if we all reinvented the wheel over and over again. It's really, I think, let's build on each other's successes, and I think we can all kind of move the needle on this difficult problem of health data sharing together. Thanks so much.
Well, thank you both very much. It's always exciting just to see the scope of this project and just the sheer volume of data that you've been able to assemble. Just trying to tie your 2 presentations together. So Amol, what was it that Chaim did in terms of his data sharing framework that opened the door for Gemini? Like why couldn't we do this before? What changed with what the work he was doing that allowed this to happen?
Yeah, I think the sequencing of things was such that sort of Gemini kind of started happening before the panel, the CCA panel. So I'm not sure that the sort of causality of the way you asked the question sort of really reflects just the timing of how this all works. I think the relevance or the value of both, and I would love to get Chaim's take on it, was the health data sharing panel highlighted a couple of things that I hope Gemini first serves as a bit of an example for, which is yes, it would be great if we had some legislative change. And yes, it would be great if provinces could collaborate more across each other. But we can do a heck of a lot even in the current context. And I think the health data panel making that clear to decision makers, because I think a lot of times what happens is politicians especially, but even government bureaucrats think about data sharing and immediately just run away from it because of this feeling that it's so complex, that it's too hard. And I hope that what Gemini can do is serve as an example that, yes, it's hard, but we can really do a lot. And so you don't need to run away from it, and the benefits can outweigh the risks, right? Like all these hospitals shared huge quantities of data with each other, and the sky did not fall down, right? And so I think just that's an opportunity. And I think, but where I think the health data panel's work is doing is, one, we need to be better about connecting these initiatives across provinces, and I think that's one of the big things that the health panel is advocating for, and allow its report kind of hopefully opens up that vision a bit more, and then really that linkage to these major agencies in the country, and really putting this on the map and giving them a way forward, I think is the major value. But I don't know if you would add anything.
I just to recognize the sequencing, and Amol will target, and I was one of the people. Well, Amol will confirm to say, why are two young researchers doing something which is destined to fail because no one else did it before them? And I was one of those people who said maybe you should try this in about 5 years when you have some experience. And
Or
they,
slash tenure, like slash
yeah,
like
yeah,
being past
10 years.
your promotion stage or whatever, the C5.
Exactly.
Yeah.
But I mean, to their credit, they've done an amazing job of putting this together with just, in a sense, this is how we do, unfortunately, it's how we do it in Canada, on a shoestring and without a proper budget. And some of the things that we've identified through the panel um, can demonstrate how, can be the identifiers of what Amol and Fahad and the whole Gemini crew have had to overcome in this, not having the incentive structure, not having the enough of the finances, not having the buy-in. And it was really by sheer diligence and grit that this moved forward. But you shouldn't need that, right? You shouldn't need to have those things as markers for success. I was talking with some of your colleagues about the challenges with Kai-Hi data from the administrative data. So Kai-Hi has administrative data from across the country, but what they have in that data is not the same as the level of detail that we have from the Gemini data. And I think what we might, if you many of you are in this field, I think what if this does anything, it'll recognize that you'll have to do it you might have to do it outside of the requirements, because you'd have to change, in a sense, you'd have to change all the requirements for data abstraction across the country for a long time in order to do this. And I think that the way to move forward on this, I think, and I'm not sure where Amol and Fahad are thinking of expanding, but there are now enough sort of electronic health record hospitals where we can bring some of these things together. Unity is moving towards Epic. I'm not sure what Sunnybrook has decided upon. I've heard various rumors, but I don't know. Sinai isn't changing from Cerner, but there's enough places where you can get a lot of these large hospitals into this. I have to say and recognize that probably the biggest, anytime I'm involved with the ministry where we're negotiating with I'm actually negotiating with the OMA, so don't shoot the messenger. But the idea that when we this is about a hospitalist alternative payment program, and we brought Gemini in to try and layer in a quality aspect to the alternate payment scheme. And sorry, I shouldn't have used the word scheme, the alternate payment plan. But the idea is that Gemini has, it's the Pareto principle. They have about 80% of the care in the province, but they don't have the majority of the hospitals, right? So the majority of a lot of the hospitals in Ontario and a lot of the hospitals across Canada are quite small. And that's part of the challenge that came up, because when we're trying to look at coming with a province-wide approach to quality improvement, that's a challenge, that they're relying on a lot of those facilities that have the economies of scale to be able to have that contact person with health data to be able to feed those things. And that is a challenge. And where Amol identified those challenges with some of the outliers, I will guarantee you there would be a lot more outliers when you're looking at smaller facilities that might not have the same infrastructure and might not have the same level of experience and expertise. And so I think that in a sense that does us a disservice from a Canadian perspective, where it doesn't mean that we should stop doing these things. We should do it as much as we can with what we have. But I think in the future, if you tell me if you're looking at a divide, like people talk about the digital divide, that's an enormous divide, right? Our divide between rural or small hospitals and larger urban ones is quite large and is enormous. And they transfuse a lot of just as an example, they transfuse blood as well, right? Melissa, I think was.
Yeah.
Hi, thanks for this amazing talk. I'm from Montreal in Quebec, and the whole province is moving to Epic. Every hospital will be moving to Epic. And we're at the very beginning, and there are only 2 hospitals that are involved in pilots. How should we, is there an opportunity for us to make sure something like Gemini is thought about at the very beginning? And if so, I'm not involved, but I would like to make sure somebody is thinking about it.
Yeah, thanks. It's a really, really good question. And it would be great to hear if there's anyone here on the call, but from folks in Alberta that have already moved to this model, my understanding is that so there's a lot of opportunity, and it's a great enabler. If we can get the whole province on one EMR, that's amazing. It's only a part of the work, because you have to then ensure that there's access to the data, that people can actually use it, and it's not too cumbersome to get. So I think it is critical to think about it up front. One of the big pieces to think about up front actually is, and I think this has to be part of the procurement process, and it's tough, but to ensure that there is a way to get the data out of Epic so that it's usable by researchers. One of the things that Epic does is push you into using their own custom platform and tools, which get very expensive every time you buy a new part of it. And so, thinking about upfront, like, what is the analytics solution? What will the downstream costs be, and how will the province plan to? Because otherwise, you don't realize the benefits of the investment in Epic. Like, you won't get the gains, at least on all of those analytic and research uses, which is one of the major reasons why it's exciting to do that. So, I think it does have to be thought of upfront for sure, but it's a super exciting opportunity.
Thanks.
Okay, I think we've got time for one more question, if anybody has one. Lanny, I see you emerging. Yes.
Hi there. Thank you so much for the presentation and doing all the work that you do. I think it's a huge success. So kudos to you. I'm a pediatric hematologist, so I'm very excited that the pediatric data is available. The one question I have, which relates to this data set, is one about cost. So is there currently a cost associated with using Gemini and its services, or how does that work if there's a project that's wanting to be done?
Yeah, thanks so much for asking. Sorry, I didn't mention it. So first of all, yeah, hopefully the pediatric data not yet available, but soon. We're just starting. So hopefully in the next 1 to 2 years, there will be a pediatric data set that you can use. So there's this, we try to keep costs as low as we can. We do need to recover costs for preparing the data set and working through all of those administrative things. So if your team is going to use the data yourselves, like with your own analyst time, then the costs are a sort of project activation fee and a data set preparation fee, which usually run around $3,000 to $5,000, and then an annual cost that is less than that, $1,000 to $2,000 per user, just for the software licenses on the platform. So we try to keep it pretty reasonable to use. And then if you want to use a Gemini analyst, we just charge that out on a per hourly basis, for analyst fees. So we're trying to make it as cheap as possible, but as Chaim mentioned, like we've been doing this on a shoestring and we got to keep the lights on. So
Great, thank you.
Okay. All right. Well, listen, we're at the hour, just a little past it, so we will have to wrap up. Thank you everyone for attending. Again, please do fill out the evaluation form, which will be circulated shortly afterwards. And again, Chaim and Amol, very exciting. I was thinking about 3 or 4 other research projects as you were going, and I'm sure everyone else is having the same wheels turning kind of experience here. So you'll be certainly hearing from our group at some point in the future, even beyond Gadget.
we would love that. We would love that.
It really is an amazing group, and most importantly, thank you, Jacob. But I can vouch for it. They're nice people to work with. So that's probably the most. It's a pleasant experience.
That's always
It's a lovely
sauce.
Canadian way to end the.
It's
Thanks, Chaim, for having me.
Nice. Yeah. Okay.
Okay.
Thanks so much, guys.
Thanks, everybody. Really appreciate it.
Bye.